And just kind of painting a scenario, because COVID-19 is the prevailing issue right now, if I was to come into a private hospital seeking treatment, I need to be there, for instance, for ICU treatment. How much am I having to cough up? Because we know insurance companies are not covering COVID-19. So how much would I need to have to pay for my treatment? And roughly how long does this kind of last?
Unfortunately, it varies from one hospital to the other, and it also varies from your condition. With COVID, different people react differently and different needs. So sometimes you will find someone who has COVID and they have renal shutdown. So they need, on top of ICU, they also need dialysis. So the price will keep on changing based on the complications COVID will give you. And that's why you cannot put a price to it. But if you look around generally, without even COVID, you will find different hospitals have different deposits. That gives you a hint on how much you are consuming. So you will find some hospitals, they will tell you it's 600,000 deposit, some 400,000, some 200,000. So you will find that that determines roughly how much you'll be spending a day. So in some hospitals, depending on your condition as well, in a day you can easily consume 50,000, 100,000, 200,000, all dependent on the condition that you have. So what I'm trying to say is the ICU is not standard. The care in ICU for patient to patient is different.
Okay, so it will vary, but you mentioned something that a patient would have to pay a deposit. I do know that the Ministry of Health had cautioned against that, especially during this time of COVID-19. How is that even possible?
I was talking about pre-COVID and other conditions.
Pre-COVID.
I was not talking. That's why I was giving you what is the prevailing prices in the market.
But has that been a scenario?
And it was for people who are paying cash. So you will find some people have insurances which covers ICU, but it might not be for COVID. But generally, that was the general prices in terms of the deposit requirements.
Okay. But has that been a scenario where people have had to pay deposits at least for booking an ICU? And this is COVID-19 cases I'm talking about.
In some hospitals, yes. Some hospitals were just giving beds if they are available. But yes, definitely, I'm sure there are hospitals that are asking for deposits. That's not a secret. It's common knowledge.
Even though it's common knowledge, we know the Ministry of Health had discouraged it. But let me go to Dr. Frank on this. You know, what are some of the factors that are driving up the cost of healthcare in this country?
Thank you very much, Victoria. So, as you've probably got from what Dr. Abdi was trying to say, it's actually a very complex issue. And when it comes to looking at, what actually makes healthcare very expensive in a country like Kenya, you need to appreciate that there's quite a few layers that contribute to that. And I like to look at it in three levels. So one's kind of the macro broad factors, and then there's the market factors, and what I call the more organizational factors. The macro factors are basically how is the health system organized and arranged. Yeah, so we like to think about ours as having a pyramidal structure with primary and community health services at the bottom and hospital services at the top, which basically means we need to put more emphasis at the bottom because it's cheaper, it's more affordable to provide services at that level. But for some reason, we've tended to invest more in higher levels of care, which of course, it's justified in some ways, but it just explains why it becomes more expensive. And other, kind of macro factors are things to do with healthcare insurance and whether we have any prepayment mechanisms. So what you call demand-side financing in health economics. So this basically means it's more affordable if you're not charging people at the point of use, because then that means it's possible that you actually engage in some kind of arrangement with providers where they provide certain values at lower cost, because you guarantee them volumes, for example, as a government. But if everybody goes on their own at the point of care, then it gets very expensive and you run into all these problems of patient detention. And at the market level, here you need to think about some of the tools that governments have at their disposal that can actually help manage the costs. So things like taxes and incentives. So if the government is taxing inputs, then this naturally translates into higher costs of care. There are countries where governments use these tools very effectively in the sense that the end price to the consumer becomes a lot lower. And of course, there are other factors, things like regulation of healthcare services, things like contracting, making sure that you're doing this well, and very, very importantly as well is just the competition, just making sure that you don't create these monopolies that then set the prices a bit higher. And then finally, Victoria, and we don't talk about this enough because most of the time we are talking about some of the factors I've talked about, things like insurance. What we forget is efficiency within the organization itself, just making sure that the hospitals, the healthcare facilities, the clinics are running, they're optimized, so that for the same dollar, for the same amount of money, you're seeing more patients. You're giving better value, safer services, fewer readmissions, fewer unnecessary prescriptions, shorter waiting time. So we don't even need to think about saving money. Just for the same amount of money, you can actually provide services for more people. And that then naturally means that as a government or as a country, we are going to be spending a lot less in providing healthcare. So those are some of the factors that contribute, that eventually lead to what becomes a high cost at the end user.
You mentioned managing the end cost to the patient. How, in a practical sense, can this happen? I know they've done it pretty effectively in India, which is why a lot of Kenyans head over there. But in a practical sense, in a Kenyan situation, how do we do that?
Yeah, so that's that's the elephant in the room, isn't it? So we've tried looking at the Indian model and why, for example, it's cheaper for a patient with cancer to book a flight, go stay in a hotel for 2 months in India and still get treatment, then come back. Why that's still cheaper than providing, getting the same care in Kenya. So there are many factors that could explain this. One of them is volumes, obviously. So for the same, radiation equipment or, for the same service that they're providing, the Indians see a lot more patients, and because of that, because of economies of scale, it means they can actually price lower. So that's a factor. But what we picked up over a couple of years of collaborating with Indian hospital operators is the fact that they've optimized their operations, and by so doing, it basically means they can still make a fairly good profit without necessarily charging charging an arm and a leg to the patient. So that's also a factor. So the biggest weakness perhaps that we have as a country is the fact that we don't quite, our health sector has remained quite insulated from some of the debates, some of the discussions around, optimizing operations and functioning properly in a very competitive market. We've kind of insulated ourselves. And by so doing, we've actually disadvantaged our patients, our communities, because then that means if I go somewhere and I'm told a consultation fees is 5,000 shillings, and I need to see that cardiologist or that specialist, I just pay it. But that is almost never charged anywhere in India. A top professor would probably be charging between 1,000 and 1,500, and that's professor level. So the differences have to do with a multiplicity of factors, and of course, not to discount the fact that the most effective way of actually protecting the patient at this point is it's just having mechanisms that ensure that they don't pay at that point. So what I was talked about earlier, which is having some purchasing mechanisms where you collect money, you pull it, and then you purchase services on their behalf. In our case, you're talking about NHIF and possibly a social health insurance system.
Right. Dr. Abdi, just from your perspective, we know hospitals, yes, they give a health service, but they're also in business. Break down the cost that hospitals incur and then, of course, have to pass on to the patient. What does that look like? Where do these costings come from? If it's from drugs, if it's from suppliers, manufacturers, break that down for us so we can actually see that chain by the time it gets to the patient?
Thank you. I will break it down, but I wanted also to clarify one thing, that not every procedure that's done in India is cheaper than the same procedure being done in Kenya. So you will find there are some which are almost the same, or there might be even higher, depending on the flights that you have taken, that you could have actually done locally. So not every procedure. As for hospitals and hospital owners, you will have a range of things that you work with. Either the initial capital to set up, which is very heavy. If you think about in terms of the building, the equipment, then on top of that you have your personnel, the people you have employed, that's your healthcare, both the non-healthcare, the back office and the front office people, and the professionals. Then you have all other inputs, pharmacy, laboratory, radiology. All these things are things that you get from different suppliers. Unfortunately, in our setup, you will find we have many distributors. And each distributor has his own markup put up on the things that you are buying, including drugs. And if you are registered as a normal company, private limited, and then you also need to pay KRA as well, other than the normal statutory deductions that you do on a monthly basis. So all those are things that you need to pay. So when a patient doesn't pay and they have consumed drugs, maybe a vial costs 20,000 shilling and they have consumed 10 of them, that's 200,000 shilling. Your supplier doesn't care whether your patient paid or didn't pay. They just expect you to pay them. And your supplier could be the doctor, could be the pharmaceutical, or could be the person who supplied you with oxygen, or the person who supplied you with radiology equipments. So you don't have an option other than paying your suppliers, and because you have contractual obligations, and you don't have an option other than paying KRA, because if you don't, they will come for you. So those are the things that people need to understand, that when you're in a hospital, the cost, this hospital is just basically passing the different components that have been used to treat you.
But even beyond that, Dr. Abdi, hospitals are also notorious for inflating costs. How can that be managed?
Actually, that could be a big assumption, because what I know for sure is there's no one who sits down in the business of saying, I'm going to inflate. What we need to understand is different hospitals have different charges, and it depends on the kind of systems that they have in place. And those are the things that Wafula was talking about. Your efficiencies, how many people are working for you, what is your salaries that you are paying, are you also giving hotel services? Because you will find some hospitals, the room is more than a 5-star, so compared to a hotel. So those are now the things that people need to understand, that what you pay depends on the services and the things that you'll be given by that hospital. And different hospitals have different prices,
right,
depending on their input and how they are doing their calculations.
And let me bring Dr. Frank in. We're running out of time really quickly because we need to kind of get the solution to this. In terms of the way forward, paying out of pocket for healthcare, not sustainable, right? So we need to get more people insured and with some sort of coverage. And you mentioned NHIF. We keep hearing universal healthcare. There were pilots done in this country. How successful they were, we don't know. But, when we're trying to think about such interventions coming into play, what is the practical solution? especially now when you're looking at so many Kenyans having to fork over so much money. You know, we always say that people are a hospital bill away from poverty. It's a serious issue. So how do we begin to remedy it from the position or the perspective of insurance coverage?
Yeah, so Victoria, the good thing is, and sometimes we scatter around the issues, but the good thing is we actually know what we need to do. And I'm sorry to say, and it makes me sad to admit this, but I think there's a lot of political interference and political processes that stop us what we need to do. So Victoria, you're asking what is it we're supposed to do? We need to expand. If we've decided that we are going the social health insurance way, which is kind of a consensus based on the current discussions around UHC, then we need to just be brave enough and come up with a very clear plan of scaling up our social health insurance scheme. So that basically means turning NHIF as it is right now, which is primarily driven and owned by the members, to actually a social health insurance scheme where still the members contribute, but also you have the government putting in a sizable amount of money to cover perhaps the indigents and those who are less able to pay. But that needs to be backed up by making contributions compulsory one way or another. And for a country with such a huge informal sector, this is something you're going to have to sweeten this pill. So you can't use the traditional enforcement method. So you basically need to create a very attractive value proposition around it, but also have legislation that backs that. If you have employees, if you're an employer or if you're a citizen and you actually require these types of services, then you actually need to be under an insurance cover. What some countries have done, Victoria, is they've created a certain package and they've actually made it compulsory under what we could call the UHC cover. And that basically means it's not possible for you to receive these services from your private insurer or from somewhere else. You have to go through this cover. And that basically means, Victoria, you have no choice. Whether you're the kind of person who feels I can't use the national cover and I prefer to go, you still contribute there, because if you get TB, if you get one of those ailments that are within that primary cover, you have to go through the national scheme. The whole idea is not just for people to contribute, it's also for people to actually, including able people who have private insurance, to still use this service, because that's how you drive change. That's how you demand better. But if you leave it as a cover for indigents and the less able, then you end up perpetuating a problem where this is actually seen as a side, something side, but I actually have my main cover in place. And then finally, even as you're doing this, the insurer needs to up its game. Administrative costs are too high, so we don't think that we are getting value out of NHIF as is now. To be fair, there's been lots of improvement. It has been improving, successively across, I would say, decades perhaps. But the truth of the matter is NHIF needs to come and just have a very narrow and clear mandate, what we call strategic purchasing, really. Get this money in a pool, which basically means everybody's in there, the sick and those who are not sick, the old and the young, those who are able and those who are less able financially, everybody is in that pool. So you actually end up with not a sick pool, but you actually end up with a very fair pool where anybody who needs care at any given time gets it. But then they're purchasing services effectively and they're getting value for money. So if it's a cesarean section, you're purchasing this service. And Abdi will tell you, and I know the private hospitals, have actually been, involved in some of these discussions. At the end of the day, the solution isn't necessarily hammering down on the private hospitals and trying to get them to reduce costs. The main solution really should be, and this is very important, it should be making sure that the financing system gives the patient the power to decide where they want to go and get the care. And it doesn't matter. It's very unfair to have a system where certain hospitals, and I won't mention them, get a huge amount of money, yet there are public hospitals and certain facilities that are neglected. You need to standardize this so that if I need, my wife needs to get a cesarean section, I will actually go to my preferred facility without worrying whether it's public, private, big, small, or that kind of thing. I'm going there because that's where I'm most comfortable. That way you end up pulling a lot of people into this pool, and you actually end up, increasingly improving, the coverage in terms of financial risk protection.
Great insights. Thank you so much, Dr. Abdi, Dr. Frank, for your time. That's all the time we have. Let's take a short break here on Citizen Weekend. Sports news coming up next. Kenya to host a Congress for all African members of the FIA. We tell you when and why after the break.